we have a patient with hypochromic anemia. When we say hypochromic, it means that, how do I even put itself? Color index is low. I don't know if you know about color index. Color index is low, and color index is normally controlled by what? Hem. And inside hem, we have what? Iron holding them together. You see, so if you say we have somebody with hypochromic anemia, it means that the hem is not sufficient. And if hem is not sufficient, it means that the iron is not what? Sufficient. Technically, that's what it means. Now we're having what? A splitting hair. So again, to confirm what we are talking about. So here we are talking about what? Iron, splitting hair, and loss of hair. Increase in nail brittling, taste alteration. Obviously, this is what? A problem with what? Iron. So this is deficiency of iron-containing enzymes. And actually, if you are looking at this question and you can remember your biochemistry, they are more related. They are more related. So this one, we're going to enjoy them. All right. Because most of the time, we would have done it. All right. We're having a 27-year-old woman has dropped penicillin-containing eye drops. Okay. In few minutes, there appeared feeling of itching, burning of the skin, the lips, eye edemas, wrestling cough, and decreasing of BP. Now I'm going to do something here that I'm not doing, but now I should start doing. Guys, look at this, because I'm going to ask some of you one of you a question. A 27-year-old woman, after the drop of penicillin, started having itching, burning of the skin, the lips, there's edema, and there is whistling cough, and there is decreasing of blood pressure. Paul, what is your diagnosis? What did it happen to this woman? Dr. Paul, just try.
Allergic reaction.
Allergic reaction. Thank you. Allergic reaction. Allergic reaction. What type of allergic reaction?
Hypersensitivity.
What type? We have 4 types. Which type?
Type 4.
Type 1.
Type 1. They said in few minutes.
Oh.
Dr. Paul, watch in few minutes. So please let your eyes be open, because that's what I'm saying, that this is sweet. Because if you understand what we have done, you should be able to understand these small things. In few minutes, the other one, they said in a long time, after applying, I think, a lipstick or something like that. So please, in few minutes, there's itching, there is this. So this is what type 1. Type 1. And in type 1, if you want to know the pathogenesis of type 1 hypersensitivity, you must know that in type 1, there is always IgE immunoglobulins. IgE immunoglobulins. And I said earlier on that immunoglobulins are produced by the plasma cells. Plasma cells. So all these are actually produced by what? Plasma cells. Because they are all what? Immunoglobulins. They are all what? Immunoglobulins. So in allergic type 1, we are having immunoglobulin what? E. Because immunoglobulin E attaches itself to a mast cell. And that mast cell, because of the attachment of these things, when another substance that is allergic comes in, they begin to what? Undergo what we call degranulation. And this degranulation now releases their enzymes, like the histamine, and they start causing the problems that we have, like the itching and then all those things that we have. So again, in type 1, you will see what? IgE. And the most abundant immunoglobulins is IgG. That is what the most abundant type of what? Immunoglobulin. The most abundant type of immunoglobulin. Because it protects against bacterial and viral infection. Bacterial and viral infection. Now, in IgM, I'm just for education purposes. IgM. It is the first antibody that is made to fight a new infection. So if you have a blood analysis and they tell you that there's IgM, it means that that infection is a new infection. The patient has not had that disease before. It's a new what? Infection. So you see IgM, new what? Infection. New infection. I've already told you about IgE. It's for what? Allergic what? Reactions. Now, IgD. Usually, its mechanism of action is not really understood because it is in small amount or it is in small quantity in the blood. It is in small quantity in the blood. So over here, we are taking off IgE and then IgM. So your answer is A. Your answer is A. All right. A patient underwent a surgery for excision of a cyst on a pancreas. After this, he developed hemorrhagic syndrome. Now, up until now, many people know that when people do surgery, sometimes they bleed, but they don't know the mechanism of the bleeding. But this was hemorrhagic what? Syndrome. And they are saying that apparent there's a disorder of blood coagulation. Please write this down. Write this down. Write this down. In surgery or during surgery, all inactivated enzymes become activated. Again, all inactivated enzymes become what? Activated. It becomes activated. So what it means is that, so in coagulation, for instance, now coagulation means what? Clotting. Coagulation means what? Clotting. So when there is no clotting, it means what? Things are, it means bleeding will what? Will ensue, or bleeding will what? Will happen. And again, in now one mechanism where bleeding will continue is that there is activation of what we call plasminogen. Plasminogen. And it converts plasminogen into what? Plasmin. Write it down. There is activation of plasminogen into plasmin. And the conversion of plasminogen into plasmin leads to what we call fibrinolysis. Fibrinolysis, meaning the destruction of what? Fibrin fibers. And you know, fibrin are like a mesh-like structure on a wound. Imagine Yima is bleeding. Okay. Yima vessel will try to constrict. After constricting, the coagulation will now come to play to form something like a thick substance and something like a thick layer on the skin. If Yima can attest to that, in fact, everybody can attest to that. You begin to use, you have a very thick skin at the area of injury or where the bleeding was. And when that thickness comes, it begins to stop bleeding. That means there is what? A clot forming there. And this clot is made up of what? A mesh-like structures. Mesh. It's like a mesh. It's like a mesh. So when this mesh begins to be destroyed, we call it what? Fibrinolysis or fibrinolysis. Fibrinolysis. And I'm saying that in surgery, there is the conversion of plasminogen into plasmin. And that leads to what? Fibrinolysis. So in this case, what should be your answer? Or the cause of the disorder of blood coagulation? And your answer is what? Activation of fibrinolytic system. Activation of fibrinolytic system. So your answer is B. Your answer is B. All right. Mm-hmm. Look at this again. We have a 3-year-old male patient with thrombopenia. That means no or not enough what? Platelets, isn't it? Good. There's reduction of fibrinogen. When there's a reduction of fibrinogen, what happens? It means that fibrin will not be enough. And now look at it again. There's even product of degradation of fibrin. I've already explained to you that fibrin is involved in what? In that mesh-like or in that clots that is formed on your skin when someone is injured. And now look, there's now what? Petechial hemorrhage along with septic shock. Along with shock. That means that these hemorrhages are becoming so severe that it has now led to what? Low amount of what? Fluid in the vascular system, thereby leading to what? Shock. Thereby leading to what? Shock. And the question is, what is the most likely cause of these changes? What is the most likely cause of these changes? Usually we're having everything. So you don't have platelet, you don't have fibrins, everything is a problem. And this phenomenon is called disseminated intravascular complication, also known as what? DIC or coagulopathy. Usually the right term is coagulopathy. So we call it disseminated intravascular coagulopathy. Coagulopathy, meaning the coagulating system is faulty and it is disseminated everywhere. That means it is spreading everywhere. That is what over here, your answer will be what? A DIC syndrome. Because platelet is not there, fibrins are not there, clotting factors are having problem, everything is problematic. So this is what? DIC what? Syndrome. DIC syndrome. DIC syndrome. So the answer is E. Good. Pyruvate. This is this girl's favorite question. Yara, your favorite question. Pyruvate. So what do you think about? Vitamin B1. We'll talk about this. Vitamin B1. So if pyruvate concentration is increased 10 times the normal, what deficiency? It means vitamin B1 is 40. Vitamin B1 is 40. And when we said vitamin B1 produces what? Thymine pyrophosphate, which is a coenzyme or a cofactor for the pyruvate what? Activation. So here, the answer is what? E. Vitamin B1. So this, if you see a question like this, and you are gone. A person has a stable heart rate, not more than 40. Not more than 40. What is the pacemaker of the heart rhythm? What is the pacemaker of the heart rhythm? Now write this down. Write this down. The natural pacemaker of the heart is the SA node or the sinoatrial node. Sinoatrial node. That's the normal pacemaker of the heart. And it beats around 60 to 80. It beats around 60 to 80. Now, if you have AV node or atrioventricular node, it beats between 40 to 60. 40 to 60 is atrioventricular what? Node. And then less than 40, you are thinking of what? The bundle of His. The bundle of His. The bundle of His. Less than 40. The bundle of His. So now we have not more than 40. That means it's around 40. So this one we can say your answer is what? Atrioventricular node. Atrioventricular node. So your answer is what? A. AV node. AV node. All right. I love this. 32-year-old patient with gross blood loss. Gross blood loss. That means a lot of blood is oozing out due to what? A motor accident. BP is 110, respiration 22. But look at the BP. Sorry, this is pause. Now look at the BP. BP is 160. This should tell you that the volume of the blood pressure is decreasing. The volume is what? Decreasing. The volume is decreasing. So what changes is happening? There is blood loss, meaning that volume in the blood is what? Going low. And that phenomenon is called what? Hypovolemia. 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 But the real cause of this hypovolemia is called what? Hemorrhagic. So this is called hemorrhagic hypovolemia. Hemorrhagic hypovolemia. Or if it finally leads to shock, we call it hemorrhagic shock. Hemorrhagic shock. Hemorrhagic shock. So your answer here is what? A. We are having a 70-year-old suffering from atherosclerosis. By now, you should know what atherosclerosis is. However, atherosclerosis is simply the thickening of the vessel. But usually, we normally refer it to when there's what? A plaque inside the vessel. When there is a plaque inside, when I say plaque, it's like an obstruction. As a result, there is a reduced flow of blood through the vessel. We call it what? Atherosclerosis. But usually atherosclerosis occurs at the coronary artery, the artery that supplies the heart with blood. The artery that supplies the heart with blood. That's where it normally what? Takes place. However, the question is not about atherosclerosis. The question is, it has been complicated by lymph thrombosis. Again, what it means is that this thrombus has gone on to what? To block the vessel. And when vessels are blocked, what happens? Necrosis. And a gangrene is a type of what? Necrosis. Gangrene is a type of what? Necrosis. That means that the lower extremities are not having what? Enough blood into their tissues. So they're going to go through what? A gangrene formation. Now the question is, what is the most likely cause of thrombosis? Thrombosis. Now, thrombose, like we normally said, is like clotting inside the what? Inside the vessel. Someone said I'm moving fast. That's why I'm trying to speak slowly for us. Okay. Now, when we say thrombosis, we're referring to what? Clotting inside the vessel. Clotting inside the vessel. And of course, before clotting will take place, there is what we call thrombocyte aggregation. Thrombocyte aggregation. That means without thrombocyte, it is difficult to arrest bleeding. It is difficult to arrest bleeding. Okay. So now over here, the question is not referring to the atherosclerosis. That's why the question is referring to the thrombosis. That's why I'm explaining the thrombosis. Okay. So again, the thrombocyte has to what? Gather. And when they gather, they must adhere to the vessel wall. And that process is called what? Thrombocyte adhesion. Thrombocyte adhesion. So when the thrombocyte begins to adhere more, that is when the coagulation factors will now begin to what? To be produced. So over here, what is the most likely cause of the thrombosis? It's because the thrombocytes are what? Adhering to the tissue or adhering to the site of injury. So this is what? Thrombocyte adhesion. Thrombocyte adhesion. Thrombocyte adhesion. So here, your answer should be A, thrombocyte adhesion. Adhesion. ECG of a 44-year-old reveals signs of hypertrophy of both ventricles. I don't know if you have said it over here, but anytime you hear of hypertrophy, it means that the heart are what? Enlarging. The heart valves the heart ventricles are enlarging. They are enlarging due to what? Either they are pumping too much blood or the blood is not able to flow or to go. The blood is not able to go. So there is a lot of blood there. So it is not going. So it begins to force itself to adapt and be able to pump that enough blood inside it. Okay, good. And they are saying that it's occurring at both the ventricles and the right atrium. What does the right atrium do again? The right atrium receives blood from the superior and the inferior vena cava. They receive blood from the inferior and then the superior vena cava. Okay, now look at this. Patient was diagnosed with tricuspid valve insufficiency. Tricuspid valve. Now, tricuspid valve is the valve between the right atrium and then the right ventricle. The right atrium and then the right ventricle. That is where the tricuspid valve is located. So when there's a problem with the valve, what it means is that there will be what? A backflow of blood. There will be regurgitation. So instead of the blood to flow out, the blood flows backwards. The blood flows backwards. So when the blood begins to flow backwards, what happens? It means too much of blood can accumulate in the ventricle without being expelled or without going into the systemic circulation, whatsoever you might put it. Do you get me? So basically, that is what is happening. So as a result, there'll be too much fluid in the ventricle. And when in the ventricle. So when there's too much fluid in the ventricle, as established earlier on, the ventricles begin to now adapt to pump it. So it begins to enlarge, to gather muscles, to enlarge so it can pump it. That's what we have the hypertrophy. So over here, you are thinking of what? Overload. An overload of fluid overload. Fluid overload. Fluid overload. So here, you are thinking of what? Heart overload by volume. Volume means, of course, is the fluid that is being there. Volume. All right, so the answer is D. Shock. You know, in shock, there's always decrease of what? Blood pressure. Shock, there's always decrease of what? Blood pressure. They say shock and signs of acute renal failure develop in the patient due to permanent injury. What is the cause of the development of the acute renal failure? Of course, shock means what? There is the decreased amount of what? Fluid in the atrium, or there's what? Hypotension. And when there's hypotension, it means that the kidney will not get enough blood to function. To not get enough blood to function, so it will undergo to what we call hypoperfusion. It undergoes what we call hypoperfusion. And when it goes through hypoperfusion, it begins to what? To undergo what? Failure, because every tissue in the body needs oxygen. And here's the case, because of shock, there is not enough amount of what? Oxygen coming into the what? The kidney. So as a result, the kidney begins what? To fail. So what is the underlying mechanism of the development of the acute renal failure? And of course, your answer is what? Decrease of what? BP. So decrease arterial pressure. Decrease arterial pressure. As simple as that. Now look at this. A substitution of glutamic acid on valine. This one, every medical student should know it. Substitution of glutamic acid on valine is what? What pathology is it? Of course, sickle cell. Sickle cell. Sickle cell. So instead of having a substitution of glutamic acid on valine, so instead of having either glutamic acid, the valine is now what? Being present. So you're substituting the glutamic acid for valine. And that is what called sickle cell. Sickle cell. Sickle means the cell becomes what? Crescent in shape or sickle in shape, and hence the name. In some questions, you will see erythrocyte of modified form or low hemoglobin. Erythrocyte of modified form. Modified form. Please note, modified form. We start a question like that in the biochemistry. That's why I brought it up, so that you can revise it as well. So your answer here is D. Now, inflammation is characterized by, look, first of all, look, there's penetration of the vessels of micro circulation stream. That is one. Two, there is increasing of the fluid dynamic blood pressure. Dynamic blood pressure. So that means you think of what? Hydrodynamic. Okay. Now there's again increasing of what? Osmotic concentration. This could be described as what? Colloid osmotic. It could be a colloid osmotic. In the what? In the intercellular what? Fluid. Now, what kind of edema will appear? Look, every kind of edema is appearing because we're having what? Hydrodynamic, we're having colloidal osmotic, and we're even having membranogenic because they pass through what? The vessels. The vessels are membranes. So they pass through what? The vessels. So this is actually what? Everything some. So we call it mix. 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 No, this should be mix, not C. This is not colloidal osmotic. This is mix. Mix. The answer is D. In Krok, it is D. I made a mistake here. So it is D. All right. Please take note. This is D. This is D before you go and get it wrong. This is D. Mix. All right. I love acid and base question because none of my students must get acid and base question wrong. None of my students, because I've explained it before. However, now let's just a quick revision. We said in acidosis, there is what? Too much of what? Hydrogen ions. In alkalosis, there is low what? Hydrogen ions. Low hydrogen ions. Now, in metabolic or in excretory acidosis, it means that patient is having what? Is having diarrhea. So diarrhea is a very good example of what? As metabolic acidosis or excretory acidosis. Now, with metabolic alkalosis or excretory alkalosis, we are thinking of what? Vomiting. Vomiting. So how do I remember this? Look, when you are vomiting, there is bitterness in your mouth. Bitterness. Now that bitterness signifies what? Acidity. So imagine yourself excreting the acid out of your system. What will be left inside your body? Of course, alkaline solution. Aha. So if you know this, then the opposite will be true for diarrhea. As simple as ABCD. Again, if you are thinking of alkalosis, vomiting is one of them. Why? Because in vomiting, you experience bitterness, which is acid in your mouth. That means the acid are being excreted. So your system will remain what? Alkaline. The opposite is true for acidosis. Now, the same mechanism is true for respiratory alkalosis and respiratory what? Acidosis. Just that this one, it involves what? Respiration. It involves what? Respiration. And then when we have, I'm just explaining it before we go to the question. Now, when you have hypoventilation, that means inability to actually what? Breathe in and out. Hypoventilation, you are thinking of acidosis. Now, why am I saying you're having acidosis? Because, how do you call it? Carbon dioxide will not be excreted because you cannot breathe in and breathe out. You are having what? Hypoventilation. So more carbon dioxide are built up in your system. And when more carbon dioxide are built up in your system, which is acidic, it causes what? Acidosis. Acidosis. Now, in hyper or hyperventilation, where there is too much of oxygen, it becomes what? Respiratory alkalosis, because too much of oxygen will lead to what? Alkaline solution. Great. So, I believe you've gotten it. If you've not gotten it, please, you can let me know. I will explain it again, or do well to watch the video again as a revision. So now look at the question. A patient suffers from disrupted patency of the airway. When we say disrupted patency, That means that the airway is obstructed or is blocked. At the level of the small and medial sized bronchial tubes, what changes will be formed? Again, if respiration is not taking place because there's blockage, that means that the person will go through what? Hypoventilation. Hypoventilation because there's blockage. Hypo. So in hypo, what do we have? Of course, acidosis. Acidosis. The answer is A. That's why I say you can't get any question under acidosis and alkalosis wrong. If you get that wrong, personally, I'll come to the exam room and lash you. All right. A 62-year-old patient was admitted to the neurological department due to hemorrhage. There's brain hemorrhage. The condition is severe, that's grave. There is observed progression. Look at this. There's a progression of what? Deepness and frequency of breath that turns into reduction to apnea, and the cycle continues. That means, first of all, the person have what? Deep breathing, going fast, and then to reduce. Deep, going fast, and then to reduce. Deep, going fast, and then to reduce. This phenomenon is called Cheyne-Stokes respiration. Cheyne-Stokes respiration. I repeat, this phenomenon is called what? Cheyne-Stokes what? Respiration. Now, in Kussmaul, we have what? Shallow breathing, but it is what? Hyperventilation. Okay. But it is what? Vigorous inhalation and what? Active what? Exhalation. Vigorous. Very, very vigorous. And it is very, very common in people suffering from what? Diabetic ketoacidosis. Diabetic ketoacidosis. That's Kussmaul breathing. Kussmaul breathing. So over here, you are thinking of what? Cheyne-Stokes respiration. Cheyne-Stokes respiration. So your answer is A. I love this question. You remember I was telling you that we have SA node, AV, and then bundle of His. Good. Now, all these things are all places for conduction. Or they are, basically that's it. They are the connecting point. For example, when the when the synovial node fires, when it fires, the muscles in the atrium picks it up and conduct it, and it gets into the AV node. The AV node will also fire. Then to go to the ventricles, then it will go to the bundle of His, then also fire. Then it'll start going to the Purkinje's and all those things and so forth. So it's a conduction system. But let's look at this thing. Some of the conduction system could be blocked. Okay. So let's look at it in this question. The question is, a 45-year-old patient on ECG was revealed. Sinus rhythm. The number of auricular complexes exceeds the number of ventricular complexes. What it means is that it is not moving in the right proportion. For example, when the atrium is contracting, it's supposed to, also have a corresponded, or it's supposed to pass it on onto the ventricles to also contract. But they are saying that the number of maybe the atrium contraction is higher, or it exceeds the number of the ventricular complexes. And what connects between the auricular or the atrium to the ventricle is actually what we call the AV node. The AV node. Or the AV septa. Anyway, you want to put it. The AV node. So that means there's a problem with atrioventricular node. But what type? There are two types. There are three types. You can have type 1, type 2, and even a complete block. Now, Look at it. There's a progressing extension of the PQ interval from the complex to the complex. Fallout of some ventricular complexes. All that is saying that it's explaining that why the auricular complexes exceeds the ventricular complexes is because there are some fallout of some ventricular complexes and so on. And then see, P wave and then QRST complexes are without changes. That means the P wave is functioning. QRST also is functioning. So it's supposed to be what? All right. But here's the case that the thing or the conducting between the P wave and the QRS complex is faulty. Or there's a problem there. So the contraction is not moving what? Accordingly. It's not moving what? Accordingly. So what type of heart rhythm dysfunction are we talking about? And over here, your answer is what? Second degree. Second degree. Second degree. Because now, first degree is hardly seen because it doesn't really have much effect. So first degree normally can go unnoticed. Okay, it can go unnoticed without even you feeling anything. But with second degree, you have all of these things happening. You have all of this that they've explained happen that the auricular complexes are exceeding the number of the ventricular complex and stuff. But with complete atrioventricular blockage, there's no connection even between the P wave and the QRST. No connection at all. So they will tell you that the P wave is independent. So the P wave is standing on its own. The QRS is also on its own. That is the differences. That's a complete blockage or complete heart block. Complete heart block. No impulses is passing from the SA node and it's reaching the ventricles. No, it doesn't reach the ventricles. Though it will pass through the P wave or the, when the atrium is contracting, we call it the P wave. Please note that. Good. So, no connection. But at least in second degree, there are some bit of connections between the two, like we're having over here. So here, you are thinking of what? Oh, why did this make the mistake? So this one, you're thinking of what? Atrioventricular what? Block of the second degree. It's a mistake by me. It's a mistake by me. So I was in a hurry to project it. So the answer is what? B. Sorry, the answer is A. The answer is A. Sorry, the answer is A. So please take note. The answer is A. A. Good. All right. Oh, this is so sweet. Charlie, Pathophysiology is nice and sweet. 57-year-old student was admitted to the gastroenterological department with suspicion of Zollinger-Ellison syndrome. Please, when you see this one, this is just a disease. It's just a tumor in the stomach. It's a tumor in the stomach. And of course, when the tumor in the stomach, what will it lead? To lead to increased secretion of what? Of acid. To lead to increased secretion of acid. So this person can develop what? Peptic ulcer because of too much of what? Acid. Too much of what? Acid. Too much of what? Acid. And look, so the cause of rapid increase of the gastrin level. Gastrin also contains what? HCl. HCl is there. What disorder is there? So there's what? Hyper acidic what? Hyper secretion. Oh, why am I giving wrong this thing? So so this is B, not A. This is B. Oh, sorry guys. That's what happens when you are very busy. So this is what? B. B, hyper acidic hypersecretion. Hypersecretion. So the answer is B, not A. B, not A, please, not A. A woman who has 3 sons, 3, are affected by color blindness. Okay, 3 sons. Say a woman with 3 sons. A son genotype is what? XY. 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 Good. So let's continue. Now, since they are saying they're talking about the mother, that means it could be a problem with, okay, let's continue. So color blindness who were born after her 2 miscarriages. Children both of her husbands are healthy. Okay, that means that this husband has married the woman, how do you call it? Maybe the
2
woman divorced.
marriages, sir.
Exactly. Good. Oh, 2 marriages after miscarriages. Sorry. Can you imagine? Thank you, doctor. So what? So we're having what? 2 marriages. That means she could have divorced in the first one. Now what? But then the children of her husbands are healthy. So again, that means this is not a problem with Y chromosome, but rather what? X chromosome. This is a problem with what? X chromosome, not Y. Because if it was Y, then go thinking of what? The man's children also having what? A defect. But here's the case. The man's children are not having what? Any what? Defect whatsoever. Any defect whatsoever. So what is the most probable possible pattern of the inheritance? Again, if it is, now we've concluded that it is an X chromosome, right? Now, if it is an X chromosome, is it dominant or recessive? Now, they say the mother is what? Healthy. Healthy. And you know mothers have XX. The mother will have what? XX. XX. So for her to be healthy, it means that it is recessive. Recessive because you must have 2 recessive gene or allele before it can express itself. So the woman is a carrier. It's a carrier. And the one responsible for this disease is recessive. So this one, we are looking at for what? An X-linked recessive chromosome or inheritance. An X-linked recessive. So the answer is A. X-linked recessive. All right. This question also come a lot, so please take note. Upper neck node of a sympathetic trunk was removed from the rabbit on an experiment. It was removed. There's already an increase in temperature of the skin of the head is observed. What form of peripheral circulation is being observed in the rabbit? So over here, we're going to look at the difference between neuroparalytic, and then neurotonic. Neuroparalytic and then neurotonic. So what is a neuroparalytic? Arterial hyperemia. Of course, there'll be hyperemia or arterial hyperemia. Simply means that there is what flow of what? Blood to the area. Flow of blood to the area. So now, what is a neuroparalytic? A neuroparalytic arterial hyperemia occurs when the tone of the vasoconstrictor centers and nerves decreases. Again, when the tone of the vasoconstrictor centers, you know, in the brain we have centers for vasoconstriction and vasodilation. So we are saying that in neuroparalytic is when there's a problem with those centers, vasoconstrictor centers, and the nerves are decreased. Now, in neurotonic, it is based on the predominance of the effects of parasympathetic nervous influences. Parasympathetic nerve influences. Now, let me just go back to the neuroparalytic. It is also accompanied with sympatho. How do you call it? when there's a cut of the sympathetic nervous system, good. When there's a cut of the sympathetic nervous system, so it will lead to a decrease in the nerves that controls what? Vasoconstriction. Vasoconstriction. Good. And neurotonic, it deals with what? Parasympathetic nervous system influences. Parasympathetic nerve. Parasympathetic nerve. So if you look at this question, we are dealing with what? The sympathetic nervous system being cut. Sympathetic. So if it is sympathetic, you are thinking of paralytic. If it will be parasympathetic, you could be thinking of what? Neurotonic. Neurotonic. So please take note of these differences. So here we are talking about neuroparalytic. Neuroparalytic. No. This is not venous hyperemia is even totally out. This is what? Neuroparalytic arterial hyperemia. Arterial hyperemia. So your answer is A, not D, please. It's A, not D. It's A, not D. All right. Sometimes it's not easy putting all these questions, putting them on PowerPoint. It's not easy. So please just bear with me, okay? And because yesterday I went to chill with my family. So I was so busy throughout the night. So I couldn't get time to work on the videos, okay? All right. Now, a couple came for medical genetic counseling, okay? The man has hemophilia. Hemophilia. Now, you must know that hemophilia is X-linked recessive. Hemophilia is X-linked. It deals with the X chromosome. X-linked, X genotype. Now, look at it. They said the woman is healthy. And there were no cases of hemophilia in her family. That means everybody is fine. Although there could be what? Recessive. But they are all what? Fine. But look at the question. What is the risk of having a sick child in this family? What
So
is
did you say it's X-linked?
It's X-linked, yes. X-linked recessive. X-linked recessive. X-linked.
Hemophilia is X-linked.
Yes. It's not Y, it's X-linked recessive. X-linked recessive. So now the question is, what is the risk of having a sick child in this family? What is the risk of having a sick child in this family? So now they're saying the man has the hemophilia. The man is having what? Hemophilia. So let me quickly draw this thing over here. Forgive me. So this is the man XY. So let's assume that the person with let's say hemophilia is H. Okay. Trying to draw something. Okay. At least makes sense. So having HXY, let's say the woman is what? XX. And they say the woman is healthy, right? And they didn't say she's having either career or not. They say she's completely healthy. In her family, nobody is having it. That means nobody is actually having it. So it is 0, 0. What it means is that this will combine with this. Okay. Again, this will combine with that. And then this Y chromosome will combine with this. And then this Y again will combine with the X. So now let me write the genotype over here. So here we are saying this what? XH, X, and then with the H. Let me just use one. X prime. X prime. And then we have what? X. Good. Now we have what? X prime again. X prime. and then what? X. I wish I was using my mouse, so it'd been easier. Then here we have what? XY. Don't say YX. They don't like YX, but it's the same thing. It's XY. Just so to make sense for us. XY. Then again, you have what? Another XY. Good. Another XY. Good. So now look at it. Two boys, two girls, and then two boys. So these are the boys. These are the girls. So would they have, now having XX, X prime and X doesn't mean that you have. It means you are a carrier. So the girl is a carrier, or the two girls will be carriers. Two girls will only be what? Carriers. It doesn't mean that they have the hemophilia. They are only what? Carriers. The boys completely nothing. So what is the risk of having a child with that disease? And the answer is what? 0%. 0%. So your answer should be what? D. 0%. 0%. I hope you guys have understood this. That I took my time to draw the diagram so you guys will see. So it was 0%. All right. Good. We have oval and round organelles with double wall as seen on the electron microscope. The outer membrane is smooth. The inner is folded into cristae with enzyme ATP synthetase. ATP synthetase. Even if you don't know, you know that the powerhouse of the cell is what? The mitochondria. The powerhouse of the cell is what? Mitochondria, because it has what? ATP for synthesis of what? ATP. For the synthesis of what? ATP. So over here, you are thinking of what? Mitochondrial. And of course, it has two membranes. The inner one is folded into crystal. Okay. Unfortunately, I don't have the diagram to show you. But this is what? Mitochondria. All right. Good. Now, a tissue sample of benign tumor was studied under the electron microscope. A lot of small spherical bodies consisting of two unequal subunits were detected. What are these? Look at it. There's what? Benign tumor. There are a lot of what? Spherical what? Bodies. Spherical what? Bodies. Consisting of two subunits. Two subunit. And normally, the organelle that had the kind of subunit are normally what? Ribosomes. They are normally what? Ribosomes. They are ribosomes. And they have a large and a small subunit. They have large and a small what? Subunit. And normally, they have what they call the ribosomal proteins, and then the RNAs. Please. So they are arranged in two distinct ribosomal pieces. And that's what we normally call it, the small size and the large size. That's what they are unequal. So this is what you are referring to, what? Ribosomes. Hey, it's ribosomes, not mitochondria. Ribosomes. Again, it's my mistake. Ribosomes. Okay. Tonight I'll go through the rest of the pathophysiology so that I correct all the mistakes. Okay. Now, a woman was sick with rubella. That is German measles, right? During the pregnancy, gave birth to a deaf child. Deaf is what you see, right? With her lip and then a cleft palate. Now, cleft palate are congenital diseases. So this congenital defect is an example of what? Good. Now, when you have a disease, when a baby has a disease or a congenital defect that is showing that is showing, we call it phenocopy, or phenotypical, or phenotypic copy. That's what we pronounce it, phenotypic copy. So phenocopy. Then we talk about the genotype or the genotypic. It refers to the chromosomal representation, just like we did for the woman suffering from, they were asking of the hemophilia, and we are saying that the person is what? XY is X-linked recessive and all those things. Those are the genotype. But the physical representation or the appearance of that genotype is what we call the phenotype. The phenotype or the phenocopy, the phenotype. So the genotype basically deals with what? The genes genetically connected. Whilst the phenotype has to do with the physical appearance of the genotype. Let's say someone is having Down syndrome, for instance. In Down syndrome, you will see a genotype of having trisomy 21. Trisomy 21. That is what the genotype. That is the genotype. Now, when a baby begins to experience that genotype, as in Down syndrome, having all those moon-like face, problem with fat on the short neck, these are what? The phenotype. Okay, the phenotype. I believe I've explained it very well. I'm taking my time to explain it so that you understand this concept once and for all. So genotype is what? Genetically inclined. Phenotype is the physical appearance of those genes the person acquired. So here is what? Phenotype or phenocopy. Phenotype. So the answer is E. Good. So another phenotype, because see, a woman was infected with toxoplasmosis, just like the woman was infected with rubella during pregnancy, and has a child with multiple congenital defects. So this is what? Phenotype. The phenotype. Now, but the question is not about phenotype or genotype. The question now is that this is a result of what? And I've explained to you guys the difference between a mutation and what? And a teratogen. And I said a teratogen is an agent that disturbs the development of the embryo or the fetus. It disturbs the development of the embryo or the fetus. It disturbs the development. So you can see this infection is disturbing the development of the baby. It's disturbing the development of the baby. So it destroys pregnancies, or it doesn't make or it gives what we call congenital malformations. Congenital malformations. Okay. Now we'll talk about mutation. Mutations deal with the genes itself. Mutation deals with the genes itself. So it causes DNA abnormalities or chromosomal abnormalities. It causes chromosomal abnormality. That's what? Mutation. That is mutation. It causes chromosomal problems or chromosomal abnormality. But teratogens causes what? Congenital malformations. So please take note of the following. So here, another mistake. So here is what? Teratogen. All right, so the answer is E. In Krok is the same teratogen. I made a mistake. Wow, some of you don't like coagulation cascade. But this is for you, whether you like it or not. Now, a patient with tissue trauma was taken to a blood sample for determination of blood clotting parameters. Specify the right sequence of extrinsic pathway. Now, we have what to call intrinsic and extrinsic pathway. And the question is, they want extrinsic pathway. Now, the extrinsic pathway is the shortest and the least complex of the pathways. It is what? The simplest, the shortest, and the least complex. The least complex. Now, the extrinsic pathway primarily involve tissue factors like factor 3. So you can write it down. It involves factor 3, factor 7, factor 7, and then factor X, factor X, factor S. So again, we have factor 3, factor 7, and factor what? Factor X. 7, 3, 7, and then what? X. That is 10. That is 10. That is 10. So that is the extrinsic what? Pathway. The extrinsic pathway. Now, the rest of the coagulating factors can move with the what? The intrinsic pathway. So over here, you are looking at for what? Okay. Good, 7, and then 10. So this should be your what? Your approximate what? Accurate answer. So your answer should be what? B. It should be B. All right. A patient with the symptoms of acute alcoholic poisoning. Someone asked me about alcohol. I think it's Yara. Please, this is your alcohol. And since you have been drinking, you see, today you are working some way. But anyways, that's what alcoholic what? Poisoning. And was brought to the hospital. What carbohydrate metabolism changes are typical for this condition? Now again, if you take alcohol, first of all, you know that you have a problem with the liver. No doubt about that. But what carbohydrate metabolism changes are typical for this condition? Have you realized that people who take alcohol normally are hungry? Those who take alcohol. So, what does it do? What does it mean? What it means is that the alcohol, it tends to what? Ethanol, right? So the ethanol will increase what we call peripheral acetate utilization. It increases acetate utilization. It increases what? Acetate utilization. It increases what? Acetate utilization. However, it inhibits hepatic gluconeogenesis. It inhibits hepatic gluconeogenesis by decreasing the concentration of what? Pyruvate. By decreasing the concentration of what? Pyruvate. It also inhibits glycolysis in the liver and the brain. That's why I said these people, they get hungry a lot. They get what? Hungry. Because there's inhibition of gluconeogenesis. When we say gluconeogenesis, it means the production of what? Glucose from non-carbohydrate what? Substances. So if you're not eating, you take alcohol, you are very, very hungry because your body cannot produce what? Sugar for you. Even if you're not eating the sugar yourself or you're eating the food yourself. So the person gets what? Hungry. So they grow very lean. Those who are alcoholic abusers, they grow very lean. So, and again, I said it's also what? Inhibits what? Glycolysis in the liver and brain. Now, when we talk about glycolysis is the process of what? Producing what? Energy. That's why they walk anyhow and they are tired, they feel dizzy everywhere because the brain is not getting the right glucose, the right energy to undergo what? Metabolism. So over here, what should be our likely answer? We are thinking of what? Glycolysis is decreased, not increased. Good. So the answer should be what? B. The answer should be B, not A. Another mistake. Should be B. Oh. Please, the answer is B, not A or whatever. Your answer is B. Please, your answer is B. the gluconeogenesis velocity is in the liver is decreased to a decreased. All right. Now, I think we spoke about radiation. A result of the damage of one zone of the atomic power plant reactor, the runout of radioelement happened. People in the increased radiation zone were radiated with 250 to 300, is it rounds? Yeah. They were immediately hospitalized. What can it lead to? Usually, radiation causes what? Decrease in, cells, or they destroy cells. They destroy cells. They destroy cells. They destroy cells. However, the more profound cell that are destroyed are lymphocytes. The more profound cells that are destroyed are what? Lymphocytes. So over here, we'll go in for what? Lymphopenia. Oh. Your answer is what? Lymphopenia, not leukopenia. It's lymphopenia. However, eventually all of them will decrease. But acutely, the first one will be what? Lymphopenia. All right. Dystrophic change. When we say dystrophic, it means destruction, right? Destruction of muscles. Dystrophic changes of the heart muscles were accompanied with cardiac activity, enlargement, decrease. Just by the way, when we talk about dystrophic changes in the cardiac muscles, which enzymes should we be looking out for? If you can remember, we talk about it. We're looking out for what? Enzymes such as what? Creatinase kinase, right? Creatinine kinase. And again, you're looking at for what? LDH1. This is just by the way. It's not part of the question. It just occurred to me that to revise it with you guys. So what do we have? Accompanied with what? Cardiac enlargement. Okay. Decrease of strength, of course, of the contraction. There's increase of blood, okay, which remains in the heart during systolic phase. There's overfilled of veins. That means that there could be what? Cardiac insufficiency. Because filling of veins, meaning there's what? Congestion. It means there's congestion. So the veins, which is the inferior vena cava, is not sending the blood to the what? To the heart. And I even tell you that there's an increased amount of blood which remains in the heart during systolic phase. And you know that in systolic, it has to pump blood out. But now there still remains of heart, blood inside. Increase. Look, it's an increased amount of blood in the heart. That means there's cardiac what? Insufficiency. So according to what state of the heart is this characteristics of? Okay. So first of all, we are talking about cardiac what? Insufficiency. Or heart failure. But there's nothing like that in this question. But the question is, I think the question should be what? What is the problem happening to what? To the muscles. And over here, we have what we call myogenic mechanism. Myogenic mechanism is taking place in the heart muscles. Myogenic mechanism. And when we say myogenic mechanism, it is how arteries and arterioles react to an increase or decrease of blood pressure. Again, it refers to how arteries and arterioles, when I say arterioles, they are the more or less entry into the capillary system. So when how the arteries and the arterioles react to an increase or a decrease of blood pressure to keep the blood flow within the normal vessel constant. To keep within it. So over here we're having what? A problem with what? Myogenic mechanism. And since there's an overfilled of veins, it means that the veins are what? Dilated. And don't forget, vessels also have what? Muscles. Vessels do have what? Muscles. Take note. So over here we're having what? Myogenic dilatation. Myogenic, it's not tamponade. It's what? Myogenic dilatation. Dilatation. So your answer is B. B. Ooh, guys, look at this. Transmural myocardial infarction. When we say transmural, it means the whole muscle layer. The whole muscle layer is undergoing what? Myocardial infarction. And myocardial infarction means what? There's not enough sufficient amount of blood supplied to it. They don't have sufficient amount of blood being supplied to it. So we're having what? Myocardial infarction or necrosis in the heart. Now, in the patient was complicated with acute left ventricular what? Insufficiency. Left ventricular what? In ventricle what? Insufficiency. So what is the most typical for this state? So when we're having left ventricular insufficiency, what can we be thinking about? Or what can we see in the patient? Again, that means that there will be what? There will be congestion in the vessels, in the venous vessels, isn't it? There will be what? Congestion. There will be congestion. There will be congestion. However, that's one aspect of it. Now, in the right, if it is happening in the right, there will be formation of edema in the extremities. Again, when there's a right heart failure, you are thinking of what? Edema in the extremities. Edema formation in the extremities. But when I mention about left insufficient, that means that the left is not able to pump the blood out. So if the left is not able to pump the blood out, what happens? It means that the blood begins to flow back, called regurgitation. So blood begins to flow back, and as a result, the blood coming out from the lungs cannot even enter into the left ventricle. Why? Because the left ventricle is full of blood, because the blood there is not even entering into the left ventricle. The left ventricle. Sorry. Blood from the lungs entering into the left atrium. Left atrium will be full, because the left atrium, the blood there is not entering into the left ventricle, because the left ventricle is having a problem excreting or undergoing systole, or sending blood for systemic circulation. So the blood are accumulating. So if you see this patient, what happens? There will be a problem with the lungs, apart from the fact that there will be hypertrophy. There will be hypertrophy, of course, and again, there will be a problem with the lungs, because there will be too much fluid in the lungs. Too much fluid in the lungs. And the medical term is called what? Pulmonary edema. Pulmonary edema. Pulmonary edema, which is the same as what? Edema of the lungs. So here, your answer should be what? Should be E. Answer should be E, not A. E. E. All right. I think we've done this one, but I'll still mention it again. Atrial hypertension is caused by the stenosis of the renal arteries. Stenosis means what? Narrowing of the renal arteries. So it led to what? Hypertension. Now, activation of what system is the main link in the pathogenesis of this form of hypertension? Guys, do you remember when I mentioned something about this? The RAS system. The RAS system, pharmacology, we talk about it. That's what? The renin angiotensin aldosterone system. Renin angiotensin aldosterone system. And we said that when renin is released, it leads to what? Convert what to call what? Angiotensin 2. Right? Yes. Angiotensin 2. Now, this angiotensin 2, we're also going to call what? Angiotensin 1. Or is it the other way? No, I'll get the exact one. But renin leads to what? The the secretion of, how do you call it? These angiotensins. And the angiotensins also get what? Activated to cause what? Vasoconstriction. To cause vasoconstriction. To cause vasoconstriction. Vasoconstriction. And again, aldosterone will come to play, and the aldosterone will release what? Or will retain sodium in the blood. And when it retains sodium in the blood, what does it mean? It means more fluid will be accumulated in the body or in the blood, because sodium is not being what? Excreted. So again, we are talking about what? Renin, angiotensin, aldosterone system. So your answer should be what? Should be A. Your answer should be A. A is your answer, not D. Good. A 12-year-old boy suffers from virus and bacterial infection and eczematous skin lesion. You know eczema already. It means dermatitis or skin infection. But there's also viral infection. There's bacterial infection. There's enlargement of the T lymphocyte. Let me underline these things. Okay? Okay? Guys, do you remember IgM? Do you remember IgM? Good. We said if it is a new infection, you have what? IgM being what? Abundant. Now, it has a normal IgA. Now, IgA are normally found in the intestine or in the mucosal membrane to serve as a what? A protective mechanism. Now, IgG, you remember IgG, was what? Revealed on what? Examination. What type of immune system pathology is presented in this what? Patient? What immune pathology is presented in this what? Patient? Definitely, this person is having what? Immunodeficiency, called severe combined immunodeficiency. I repeat, severe combined immunodeficiency. And this is a genetic disorder that is characterized by a problem with the development of the T cells and in the B cells. Problem with the development of T cells and B cells. That's what I said, there's an enlargement of the T lymphocyte and in the M, immunoglobulin M's. Immunoglobulin M. It's a problem with them. And you know that B cells leads to the production of what? Of immunoglobulins. I told you guys. So where there's a problem with the development of what? T cells and then the B cells. T cells and then the B cells. So in all, we call it what? Combined or severe combined immunodeficiency. Severe combined immunodeficiency, also known as composite immunodeficiency. Composite immunodeficiency. Don't worry, we'll succumb to Bruton's hypoagambula, whatever. Succumb to all of them in subsequent discussion. So I'll throw more light on even the George's syndrome, Bruton's problem, and all those things. We'll come about, and of course, we'll talk about the Turner syndrome, Edwin syndrome, whatever. So we'll talk about all of these things. So don't worry, we'll discuss all of them. But know that this is what? A combined what? Severe combined immunodeficiency syndrome, also known as what? Composite syndrome. So the answer should be what? A. Your answer should be what? A.